I can't believe it.
Yeah, it hurts my feelings. This is a house note. I don't want to even tell y'all what it is. Okay. It's not, is it? There it is. Great. Okay. So back to suturing. So what I always do is you want to categorize your suturing really into two big categories. One is absorbable and non-absorbable. And absorbable is the ones that I want to put in the inner layers or in areas that I don't want to have to come back and take it out, namely peds. Okay, so
That makes sense.
That's the screaming little kid.
Yes.
Okay, and if you can do that. So let's just talk about the instruments first, and we'll talk about the sutures as we go. But absorbable is one, and then non-absorbable, and typically that's always the ones that have to be removed. Okay, and there's lots of categories of those. So let's talk about the instrument right here, and this is a needle holder. And I know that because of the end here, it's blunt. See? Now, some of them have teeth on them and others don't. So these have little teeth on them. See them? I'll give you another example. Yeah, so this is flat. These are just simply needle holders. Everybody knows how this mechanism works? The locking mechanism? I'm probably offending you right now, so I'm going to say stuff you already know, so just ignore that part. But I'm going to say so basic.
I'm starting from the beginning.
The locking mechanism is that you push this end up and that one down, and the teeth go across each other, and you let it go and it locks. So that's locked, and that locks this in right here. Okay, so what I do is, that's the open, and to lock it, different mechanisms. You can always push in here to click it. Yeah, you can always hear it clicking right there. Okay? So this is the locked position. And the reason that's so important is I want to lock the needle on the end of that, and it keeps it secure in the right position. For the most of the suturing, I never put my fingers in here. I manipulate the instrument by holding the arm. Okay? So the only time I do that is when I lock it, and then I let go, and then I'm manipulating with this. Okay, so I have much more control. Okay? 90-degree angles. Okay, sometimes 45-degree, or pushing away. But it's all in my hand. Okay? Never do this. You ever seen somebody do that? That's the person leaning over the bed that's going. You ever seen somebody do suture like that? Look how I'm standing. I'm straight, my back's up, and I'm gonna last a lot longer. If I do 10 of these all day, my neck's gonna hurt. I'm gonna start walking around like this all day. Okay? And so I always put my surgical field in that makes me comfortable, as long as it's not hurting the patient. Have y'all ever done that where you're leaning over and doing that?
Kid.
Okay. You hadn't yet, I guess, but yeah. Okay. So your position is important, but holding the instrument is one of the most important. Okay. So it's going to be really hard for you not to get a needle in there and start doing it this way. Just take it out, put your hand right here. Okay. So that is the needle holder. But of course, scissors, these are curved. Okay. If you're at FA, there's like 1,200 different instruments, and they all have a name: Kelly curve, Kelly short, Okay, but for these purposes, very basic. I don't care what you call it, but you need to know the basic terminology. Okay, if somebody says you want a needle holder in your mind, you see that. Versus a hemostat. So there's varying sizes of hemostats. Those do have teeth, and they're used for different things, holding tubes, clamps, tissue in some cases. But it's not ideal for holding a suture needle. So curved or a straight little scissor is good, but you gotta have to use that to cut the thread, and then also tissue as well too. Easy. Pickups.
With teeth.
Yeah, so these have teeth. Anybody ever seen that?
Yeah, I probably did the first time, like.
Don't do that.
What I was doing yesterday was I got my Sim Suture back out.
Just don't
To
ever
practice.
do that. Always practice. Always practice doing it the right way, because you'll revert and
Right.
stick yourself. All right, so on the needle, I don't know if you can see this or not. You can look in the video if you like. So this is the curved part of the needle. This is the insertion of the thread, and it's a little more easily. It has more tensile strength right here, but also this is thicker. If you start grabbing towards the distal end where the sharp part is, you can tear that off or bend it, and that's the driving part. So we tell people to grab from the proximal end to the 1/3, okay? So if you divide the length of this entire loop in thirds, there's 1, 2/3, last third. So I usually grab on that 1/3 part right there, the first proximal third. Got that? All right, now I'm gonna hold the needle also. I want a 45-degree angle. Okay, there's a 45-degree angle right there. See it? And what I mean by that is I don't ever want to have a needle like that. It needs to look like this. I've had 4 cups of coffee. I'm surprised my hands aren't shaking. That's 45 degrees. Look at that. See it? Now, see that thread hanging around? It's going to contaminate. Oh, it just went on a sheet, and I'm fixing to drive that through their skin. No telling what's over there. E. coli, somebody spit, you just sneeze, maybe some. Okay. So what I try to do, my hands are sterile. What I try to do is to bring this thread along the length of the instrument. And I hold it with my hand. Now look, I'm not in the loops, and I've got that thread hidden behind my hand. Look, now it's not in my field. It's almost like a sewing machine. Seen people do that?
No, I haven't seen.
Because I've seen this when people are threading. I'll move out of the way, see? So I just grab it. Okay. All right, now, so that's the instrument. And so I always want to, it's just wrist. When I see people doing this, y'all know what I'm talking about? I don't want to do that. Drive them like this. Remember, that's a semi-lunar. It's almost a circle. If you push the thread or the needle this way, linear, you're just going to bunch up that tissue. It's built. The reason it's looped is because you want to complete the loop. It should be circular. The loops are like this, not like this. You understand what I mean by that? You ever seen somebody throw a stitch and they pull it way out here? It needs to flow naturally in a circle. So always think I'm throwing loops like a corkscrew. And the obviously the thread's going to follow where the needle is, but if you try to drive it out here and pull it this way, you're going to end up tearing tissue or whatever else. All right, so everybody good with that? Did y'all learn a little something?
A lot.
All right, this is the plane. This is the plane. What I want to do is to drive straight down perpendicular. I never want to go this way. Okay, so it looks like this. I'm going straight in. So once I go through the tissue, all I go do is turn my wrist and it loops around. Okay. All right, let's talk about. You ever do this in the OR? When you have sharps, you ever seen somebody grab the tip of the needle?
All the time.
To cover it?
Surgeons do that.
I like to do that, but in the ER or primary care, it's fine. But in the operating room, you want to be really careful, because if you reuse that, you weaken that tip and you drive it through, it can break off. Did they tell you in school don't do that? But I do it like I'm going to use that maybe twice, so I'm going to stick it. Did y'all know to do that? Don't ever leave it out there, because you will stick yourself. All right, so let's talk about the wound. So the wound is jagged, right? What am I going to do to prep it? Let's just say this is on some guy's forearm.
Remove all the,
Cut off the jacket.
yeah.
Right.
Mhm.
So if there's any jagged parts right here, because this is the dermis, subdermal, then we'll get some fat, and then we'll get muscle. If I see areas that aren't well perfused, I don't want to sew that because it's going to end up dying and cause infection, and they're going to come back. What about the little fat molecules? You ever seen the little globular? I know Mississippi, but everybody has that. The little yellow globs. Those yellow globs are fat, and they're very, very poorly vascularized. And with trauma, they typically die. And in a lot of lacerations, what happens is that you close it up, and that fat molecule begins to emulsify, and you get yellow drainage coming out. And the patient comes back 1 or 2 days later. It's infected. It's got yellow pus coming out. It's not infected. It's just a poorly vascularized fat molecule that's dying. So whenever I see little, y'all know what I'm talking about, those little globules that stick out, I just pick them up with my pickups, and I cut them off evenly so they don't talk off, because they're going to die anyway. Use my scissors and cut them off. All right. So before we suture it, the first thing I want to do is I want to anesthetize it. I'm going to examine the wound, make sure there's not any foreign bodies. I want to understand the mechanism. So we got to numb it up before you can do anything. So how do you choose that? You want 1% with epi, right? 3 cc's, Chris? Is that right? That's what the nurse is going to say. You need to know, because they may be setting you up or not know and just throwing stuff out there.
Mhm.
So what determines whether the lidocaine has epi in it or not?
It's gonna bleed a lot.
That's right. So typically bleeding that covers the field up, I want to use epinephrine because of the vasoconstrictive effect. It will cut off the blood circulation and will keep the field from bleeding. But it can have a detrimental effect too because of where it is. So do y'all know the kind of acronym that determines where I don't do epi?
Fingers, toes, nose, hose.
Oh, hose. Okay, good.
Yeah.
Okay. Fingers, nose, toes, and penis, but she said hose. So. I'm comfortable, my man. This is, okay. All right. Yeah, so we say fingers, nose, toes, and hose is good. That's penis. So think about those areas. Ears are also another one because they're very, very poorly vascularized. So on the tip of a finger, if you injected epinephrine, it's so much microvascular, it could vasoconstrict, and the entire tip of the finger could become necrotic. And you went from repairing a small laceration to they have to have an amputation. And doctors do it, nurse practitioners do it. But when a nurse practitioner does it, it's because you're not well trained, you're a nurse practitioner, and they say, see, that's why you don't need to do it.
Yeah.
So fingers, nose, poorly vascularized, cartilage, ears, fingers, we talked about that, and then the penis too. I can only think of, I mean, I've been doing this a long time, and even in trauma, I can think of maybe like 4 times in my whole career I've ever had to suture something in a perineum. But anyway, if you feel uncomfortable, you need to get somebody professional to do that, like a plastics guy. All right, so let's just say we'll do 1%. And how do I want to inject? So in the wound, this is traumatizing. You've cut nerve endings. They're not going to feel this. So I inject into the wound, not on the outside.
Right.
Okay, because this isn't traumatized and they're going to feel that, and that's the poke and the jump. So typically what I'll do is I'll start in the middle of the wound. If it's a long needle, if it's long enough, and I'll use 1 inch or 1.5 inches, I'll start right here. Okay, so I push in that area. I don't want to go too deep. I'm not anesthetizing the muscle. I want to get this whole area. So I inject, I insert, don't inject the medicine. So I advance all the way through, and then I inject on the way out. Okay? Is it going to hurt? Yes. Do you need to tell them that? Yes. Hey, this is going to hurt. You have stitches before? No. What's it going to feel like? It's going to feel like I got a match and lit it and stuck it in there. And it's going to hurt.
Sting and burn.
Yeah, and it's going to last about 3 seconds, and it's going to be all better. Okay? So just bear with me. So with 2 sticks, I can anesthetize that whole length. I don't want to go, That's 7 sticks. And I don't want to anesthetize non-traumatic tissue either, because that's really going to hurt. Okay? So that's kind of what you do there. So let's say we've got anesthetized. You should see blanching. Okay, so it kind of turns white. And then I'm going to explore the wound. So the first thing I do, I'm just going to separate a little bit. You can even use your hemostats to do that if you want. Pull apart. I'm looking for gravel, whatever the mechanism is, metal or whatever. If there is a propensity for this to have a foreign body in it, wood, metal, a nail, if I am, let's just say this guy's driving a bush hog tractor and something flew, high velocity penetrating, and he said, oh, it was just a cut. I don't know that there's something not embedded in there, so what do you got to do? X-ray it. Or you can ultrasound if you got an ultrasound. So a lot of times when I was working in these small ERs, I'd order an X-ray for a laceration. Like, what are you doing? And I'd get it. I'd say, you see a piece of metal right there? That's why I'm doing it. So that's one of the most highly, most frequent presentations in the ER that nurse practitioners are sued over is retained foreign bodies in a laceration. Did y'all know that?
I do know that.
Yeah. So when I see a laceration, I don't care if it's this big or this big, my alarm bells are always off. I'm like, what's the worst thing this could be? He could have a piece of wood in there and I'm fixing to sew it up in there. I don't want to do that. So ultrasound or X-ray. Okay, if you don't have that, then you still run the instrument along the wound to see if you can feel any. It's gonna feel like that. That's not right. You feel hardness. Okay, so that's what that would feel like. Then I'm gonna irrigate it. What am I gonna irrigate it with? They set you up in these kits to kind of go down the wrong path, and it just drives me crazy. You know, you open up that suture kit, and what does it have in it?
Betadine.
It's got betadine, or you had to ask for betadine, but it's got 2 little plastic cups in there.
Yeah.
All right, so I've seen nurse practitioners and doctors put straight betadine in that, and then pull it up in a syringe and irrigate it, and then wipe it out. You seen that?
Mm-hmm.
So betadine is very, very toxic, and it can kill cells. So you always dilute it. Never ever put straight betadine in a wound. Okay. There's varying degrees of that. There's surgical prep, and it's sort of a emulsifying. If you could feel the difference, that surgical prep's different. But this is that straight betadine, so you always dilute it. I usually like 6 to 1, just a little hint, because what's going to clean this out is pressure, PSI. Okay. You know what PSI is?
Pounds per square inch.
That's right. And so what I do is I get a 3 to 5 cc syringe, pull up with lots of saline and a touch of betadine, and I stick it in that wound, and I cover my hand up, and I squirt it as hard as I can. And I do, for this wound right here, 50 cc's, a lot. And when I document it, I say 50 cc's of diluted betadine and normal saline at high PSI using a 5 cc syringe, total of 50 cc's, no foreign body noted. Got it? You can even put an angiocath on the end of it and get really high PSI because it's a small one, like an 18 gauge, 16 gauge, something like that. Okay, did y'all know that?
I knew about, making sure that you clean it, irrigate, but I didn't know about, I just had already been told the normal saline.
Yeah, normal saline is just as good. Remember I said, if you don't have normal saline, the PSI is more important than the mix, right? But just don't ever do straight. All right, now let's talk about how we're gonna approach this wound. Where we're gonna start. I'll give you options. Do I want to start here because it's close to the proximal end, A, or B right here, or C in the middle?
I don't know if it's probably wrong, but I start closest to me and work away.
Okay, all right.
Wouldn't it have to do with the length of the wound?
It does have to do with the length of the wound. I'm going to show you a little trick that makes you look like Picasso.
Okay.
When I finish, I want that patient to say, hey, I got stools if y'all are tired of standing. Okay, y'all good?
I'm good right now.
Okay, all right. I want the patient to leave and say, oh my gosh, it's like a plastic surgeon. And then you have the reputation of, I want her to do that. She's great at that. Okay? So I'm watching plastic surgeons, I'm watching videos, I'm reading books, I'm practicing all the time. So when I do take care of patients, I want that to look phenomenal. And so I developed relationships. So I started working in all these ERs and like, hey, if y'all got a laceration, he's the guy to do it, man. He's better than a plastic surgeon. And it's not because I'm so awesome, it's because I worked really, really hard and I wanted that to look good. And you need to do the same thing. Let that be in your skill set that you're really, really awesome at it, okay? So to make it perfect, you can start at the bottom. The thing is, it's hard to keep them perfectly aligned because the wound could be this way, and you get down to the end, you got a little pucker and it looks off. So what I typically do, there's my 45-degree angle, get my pickup. What I'm gonna do is grab this proximal end, the middle of the wound, the very middle, okay? I'm gonna come out about 1 millimeter away from that wound. If you get too close, it'll tear when I pull through. But you don't wanna get too far out either. So look where I'm doing. About 1 millimeter. Look at my hand. Now look where I came out at. I wanna stay in that subdermal space, not in the muscle. Can you see where I'm at?
I see.
So normally I would push it on through all the way through, but I'm gonna let y'all see this. So look, 1 wrist pull. Then I'm gonna unlock it. Got it? I don't necessarily have to grab this, but I'm gonna pull it through. 45-degree angle, lock. And then I want this to come straight across. I'm gonna pick this end up, go right in this end right here, and try to come the same distance from the laceration out here as that. Okay, now look, I don't want to push it this way. I'm just going to flip my wrist. Get my pickup. Release. And pull out.
Do you always do that in 2 moves?
No, I'm just doing it two for y'all. Yeah. Especially if I got 30 to do. Did you see me sewing that up? I went, I can do it with my eyes closed because I've done it so many times. I can hand tie, I can one hand tie, I can two hand tie, I can do instrument tie, but it's because I've just done it over and over again. This is just, you don't have to be, this has nothing to do with being smart. I got a high school student right now to go, in a week I can teach him to do super. What makes you phenomenal is that you got a really, really smart brain and you know when to do it and when not to. That's the difference. This is just a skill. All right. Now look at that. So what I'm gonna do is once I get this together, look at that. It's gonna pull it together really nice. And then all I have to do is to take the distance between the end of the wound and the suture and take half of it. It's gonna be 3 sutures. Because what the patient is gonna start saying right now is, how many stitches you gonna get?
Yeah.
Hey, how many stitches is it gonna be? And they want you to say 105. And you're gonna say, I can put 2 in, it's gonna be 3. Okay, so I'm gonna pull it, leave a little length right there. Always keep, this is locked, keep the instrument in the middle of the wound. I'm gonna go around twice. 1, 2. See that? And we'll grab the end. And it's gonna make a nice little surgeon's knot that's flat. See how flat that is? It's gonna lock. Now pull this that way. I'm gonna pull the loose end on that side this time. Instrument in the middle. 1 time around this time. Grab it. I'm gonna pull this to the right. And it's locked. Now look, I can pull the knot on this side. I can pull this knot over here. It doesn't matter. You just decide which one. Now subsequent throws are gonna have the knot on that side. Okay? Then I want this to look really super like a professional, like I know what I'm doing. So what I'm gonna do is to pull these taut. And that makes them even. There's a suture.
Does it matter when you're doing the throw or the wrap if you're going away from you or if you wrap towards you?
That's a good question. So it depends on where you pull that loose end, okay? I always alternate. So I go over, the next one I go under. Okay, and that's that intertwining surgeon's knot. Okay, so I'll show you that too. I didn't mention that. All right, watch this. So what I was telling you, see the wound? See the wound? Ooh, that's even longer than I thought. I thought it was right there. So look, let's go half the distance. So here is the suture, and this is the end. I'm gonna take half the distance, and it's right there. You see what I mean by that? And it's gonna make it look phenomenal. See what I'm doing? I'm just poking it through. So I'm trying to align this with that and this with that. Pull it up, unlock it, pull it through. Okay, this one's over what you were saying. Look, 1, 2. Flat. So that was over. This one's under 1. That just alternates the locks and makes a locking knot. Pull to the side. I'm trying to keep my hands out of the way so you can see it. I want this to be even. Okay. Now, you want to leave at least 1 millimeter from the end of the incision. You don't ever want to put a knot right there. Okay? You want to leave that open. So I see 2 spots that I can go. There's the other one. I'm going to take half of this side. So look, there's the wound. It stops right there. Half the distance between here and there is there. We'll throw another one. And you keep going, and it's going to look so even. This is going to be the railroad tracks. What are they doing in their instruction? Maybe somebody's building me something over there. Okay, watch over. Middle of the one. Keep this in the middle of the one. Keep the instrument. 1, 2. Grab the loose end. Pull it to the left. Right. This is going to be under. You want to do at least 3 throws. I'm just doing 2 right now for the sake of time because your mouths are watering because y'all want to get in here and do this. They are. This is the only time I have your only attention. So that's why I'm not letting y'all do anything right now. Because y'all understand y'all are going to just do this all day long. I mean, y'all are not, you're going to have so much fun, you're not going to want to even talk to me the rest of the day. This is fine. Okay, look how nice and even those are. Okay, you just take half to half. Look. Half the distance between here and here is there. It's going to look so beautiful. So that's over. This is under. Just pull that knot through. See how it's looking? Look at that. It's almost like I got a ruler and measured it. Now look, half the distance between here and there is there. This is over, this is under. And it's never fun watching somebody else suture. That's why I'm about to stop. Okay. Man, I'm thinking about the other person that's going to have to take these out in 3 to 5 to 7 days. Okay. I always think about the person. So I know when they come to take these out. Y'all agree? Look how nice and neat that looks. Okay. So what they're going to do is I want to leave enough for them to slip the scissors out from there and pull it out. Because remember, I don't want them to pull dirty thread through the wound.
Right.
Right, so all this is snip, snip, snip. Close to that insertion point as I can. And then all they do, no retain. Hey, like that. Simple interrupted is what that is. Okay? We're going to practice this a lot. I'm going to let y'all go to these stations. I'll set up a station just like this. You have your own, very own little piece of tissue with hundreds of suture. And start practicing all these little things. Do not get in a hurry. Did you see how I just methodically did each step? Start with holding the instrument. Practice that and just do doom, doom, doom. We'll do this about an hour or so until y'all say, hey, I'm tired. And then we'll take a break and then we'll come back and do it again. And then I'll show you another suture technique. We'll learn like 4 today. All right, any questions? Was this good?
It's great.
Did
Okay,
you say how
good.
you selected the needle, the silk, the?
Oh yeah. So, thank you for reminding me. So this is silk. Silk is non-absorbable. Also proline, it's blue. Tensile strength is very important. Tensile strength means what's the maximum amount of tension you can put on it before it breaks. The numbers that tell you that. Okay? So the higher the number, the less the tensile strength. So a 6, a 5, a 6, an 8 is very, very thin. If you pull it, it'll break. A 10, 20, or 00 is really, really strong. Okay, and that what determines that is where you're going to place it. Okay, if you're doing it on an elbow, a high tension area, or a knee, you want to have higher tensile strength. So that means you're going to have a lower number. If the thread actually has a needle attached to it, lots of science and variations of that, but this will show you the actual needle size on the package. So you look on the package, some of them don't have needles on them, it's just thread.
Right.
So you got to make sure, so it's actual size, look at that. Okay. And the nurses will try to sometimes trick you or make you look bad. Hey Chris, you want a PC3 on a 204 and a tapered, right? And you're like, you might as well punch you in the face. And then you say, no honey, I want a PC4, Vicryl, 3.0. And then, whoa, I'm doing that again. I'm not hating on them, I'm just telling you.
Yeah.
It's only like 1 in 10 of it. Y'all know, everybody has somebody at their work like that, don't they? See? See? Okay. So your absorbable are ones that you put down in the tissue, and we do an inner layer before we do it on the top, and I'll show you how to do that too. You can do simple interrupted, but you can do running under there as well too, which is faster. That is either synthetic absorbable, these are Vicryl, monocryl, chromic gut is made out of biotissue. It's typically sheep gut, which is absorbable, okay? And it typically is wet too because it'll dry out. So that's the ones you open up and it smells kind of alcoholic and it's moist. That's your absorbable. As I said, you put those in inside wounds or sometimes in the eyebrow of a kid or a scalp where they'll just absorb and fall out, okay? And the reason I would do that is because I don't want somebody to have to go and put a kid back in a papoose board just to get that out.
I never thought of that. That's a great idea.
Yeah. Sometimes, you know, you got to take them out. So what I choose for kids in an eyebrow that's too big to be used for absorbable is I use very, very small proline, 6 to 80, which is like a spider web for the eyebrow. And the reason I do that is blue.
Yeah, you can see.
Because they usually got black eyebrows, so I put blue thread in there and you can clearly see it. Have you ever saw somebody suturing a hairline with black thread and you can't tell the difference they got dark hair? I don't ever do that, so I do staple. I do staples and heads mostly. But heads are very, very vascular. You definitely want to use epi for that too. All right, so I will ask y'all this in the lab. You see these little knots?
Mm-hmm.
If y'all just kind of collect them and put them in one spot, don't push them on the floor. Cause I end up having to sweep them up. And it is awkward trying to get them out. So I've learned this, we're so spoiled in a hospital, everything's disposable. There's no stuff around, somehow I get it. Well, I only have 2 employees. And I have this place clean, once a week. It's very expensive. So just even Shark's box and stuff. I have to buy all this stuff off of eBay and Amazon and stuff. Like all this stuff I ordered online. So, or borrowed or given to. My best friend's a dentist. And he had some arms, extra arms. And he's like, "You want an arm with a TV?" I was like, "Yeah." And he gave me 10 of them.
Wow.
So that's what that is.
Wow.
The rest of I just put all this, it may look professional, but yeah.
He gave you that and you advertising dental.
Oh, yeah. That's my movie star too.
Yeah.
Yeah, I've gotten him a lot.
Yeah.
You got pretty teeth too. That's natural though.
Yeah, no.
Now see, this is all crowns.
Me too.
Yeah, 20 something. Of them. Yeah. When you're ugly, you gotta do something. It's all right.
Oh, you know.
It's all right. Okay.
So
Well,
this, as far as the size, is just according to the wound size?
It is. So obviously, that's a big needle. You would never use that on a face. Okay. I got a whole bag of all kinds of stuff. Little bitty needles, and I'll show you too. On this will show you the diameter, and if you look down the point, it'll tell you what it is. Okay. So it's a tapered. Some of them are squared, some of them are hexagon. It's for surgical, a lot of surgical stuff. In a primary clinic, you always want tapered. There is a cutting needle, which you want that because that's the PC that I told you about. So it's a plastics cutting PC. So that cutting will literally cut down through the tissue. You don't want ever something blunt. So you always want one that has a C on it. That's why I ask, when you get back home, go through your suture supply. Okay? And the ones that have, you'll notice, see, that's what you want a tapered. See that little dot? It's really sharp. If you see one that's square, looks like a hexagon, get that out of your clinic. You don't need that. And I'm sure they don't, but see how sharp that is? It's tapered. Good question. All right, I'm gonna bring around some examples of absorbable and different sizes so you can see the difference. All right, let's go cut. If y'all have any more questions. Good.
So you had to decide what all you wanted to do. You had to